introduction. One-time Minister of Health here in Namibia, and a man that continues to also be at the center of discourse when it comes to health matters there. Doctor, welcome to the program and greetings to you. Good afternoon.
Good afternoon, and thanks very much for inviting me.
That's all right. And we have just joined in the studio by Dr. Emvula. She is just being guided so that she can be comfortable right here in the studio. But of course, we just want to shoot from the hip. Right, there we go. Doctor, as you just enter into our house, welcome to Desert Radio and good afternoon to you.
Thank you so very much, and good afternoon to you too.
That's right. In my introductions, Doctor, we do have Dr. Haufiku on the line, as well as from the Cancer Association, we do have Mr. Rolf Hansen. We just want to shoot from the hip there. I would like to start with you, Rolf. The very fact that the head of the state, President Hage Geingob, got to get into the public domain and say, ladies and gentlemen, I do have cancer. What does that say on its own?
Well, that once again shows that any one of us is prone to this disease. It can affect any one of us. And very often, for us as patient advocates and the voice of reality, we find when we go especially into the rural communities that there is still a bit of stigma, a bit of lack of knowledge, and people often still say, it's a white person's disease, or it's an old person's disease, or especially it's a woman's disease, because we're so focused on breast, cervical cancer. So it opens up a whole world where the entire nation now realizes that any one of us is susceptible to cancer, and it is a biological disease of the cells of the body, and we're all human beings, and despite our skin color or our background or our cultures or tribal history, we are all humans, and we can get this disease. And especially as we grow older and the immune system slows down a bit, we are prone to it. So it does definitely changes the way that Namibians start speaking about cancer.
That's right. I want to put the very same question to you, Dr. Haufiku. The very fact that President Hage Geingob to come out and actually make it known that cancer cells have been found in his body, what does that say about his leadership? And also, what does it do, especially when it comes to the fight against cancer, the stigma and perception?
Well, thank you, Kelvin. From public health perspective and awareness of not only cancer but diseases, it's a good perspective for anyone to open up. We've been having a huge problem with HIV, and it's closer. Cancer is an old biological process, like Rolf referred to, and I think Dr. Emvula will maybe elucidate more on technical aspects. But from us in the public, no matter how certain sections of the public will perceive that, and there will always be politics around it, no doubt about it. So for us in the public health space, we hope and trust that for anyone disclosing in public the state of his or her health of the disease that afflicts every human being, it's a helpful awareness campaign and a hopefully diminution of stigma and discrimination against diseases. Talking of awareness, cancer nowadays mainly kills people because of lack of awareness. In developed countries, including the United States, where the president flew to, as we are reading in the media, for treatment, cancer is a public health illness that you need to screen everyone at risk, and every living person, by the way, is at risk. But we have clear guidelines that from certain age, we all need to go for screening in order to pick up cancer early, and so that early treatment can be initiated. That knowledge and awareness in our setting is hugely lacking. And in fact, so much lacking that the public often doesn't know that there are hundreds and thousands types of cancer that can affect the human body. They only know breast cancer, and maybe it's cervical cancer, and now prostate. Well, those are the common ones, including the skin, of course, because of our setting on the planet, but not even as people as acutely aware of it. So a higher level person at the level of the presidency, minister, and other executives or national leaders coming out in public, whatever the reason may be or motivation. I think for us in public health space, it's a welcome step as far as awareness and fighting of stigma and discrimination is concerned.
That's right. Rolf, I would like you to hold on to this question in terms of the president flying out to the United States of America to seek treatment there. What does it say about our capacity here in Namibia? But while you are contemplating that question, Dr. Emvula, once again, welcome to Desert Radio. My question for you is, the presidency indicated to us that President Hage Geingob has got cancer cells. Now, we know that people actually do have cancer cells. And the problem only becomes a reality when the cancer cells become aggressive, problematic, and begin to behave in ways that can cause a sickness. What does it say when we are told that the president has got cancer cells?
Thank you very much. Like my previous colleagues alluded, it just shows that no one is immune to this disease. In fact, everyone can be affected as long as you are a human being and having cells. As far as we know, cancer develops because your cells become, one of the cells become a problem, or so to say problematic. Each one's body consists of, let's say, I'm just giving an example, let's say 100 cells. Now those cells, they have got a time span, a lifespan. They die and they are replaced by the same cells, the same size, and so on. Now, it so happened that a trigger happens and nobody up to now can actually say why. Some might say it's genetic. One cell becomes to divide more than the normal ones. So this means then your body will maybe have 120 or more cells than that. And those cells are the one that become problematic, and that's how cancer develops. So I don't know exactly what type of cancer the president has, but the cancer cells that were found, according to the media, was he had to undergo an examination in the stomach and the colon, and they found those cells. And if he has to undergo treatment, then it means that those cells are problematic and they are cancerous. So it's actually very good for us as clinicians, for a head of state to be open, because this is like, it will give encouragement to the media, not to the media, but to the public, to come out if they are worried about something. I know we are very much behind when it comes to education about cancer. Many people don't know, or they might know, or they might be afraid. They think that if they have got cancer, maybe something wrong that they have done. So for me, this is a very good thing that the head of state has come out. It will encourage the public also to come out if they have something that they are worried about, to go and seek medical attention.
That's right. Dr. Haufiku, I want you to contemplate this question while I go back to Mr. Rolf there. What exactly is cancer stigma? What exactly is that? I'm asking this question because for HIV stigma, people tend to say, oh, this person is wayward. That's why, they do have HIV and AIDS and they don't have many years to live. But what is it when we say cancer stigma? And can a head of state who occupies the highest position, most powerful position in the country, be immune from that? While you're holding that question, I want to come back to you there, Mr. Rolf. The president has flown out to the United States of America. Does it mean to say that our capacity here is not really that good?
I would like to start off by saying that the patient has the right to information, and the patient has the right to decide in partnership, in understanding and knowledge with the doctors what the best treatment outcome should be and where they should get treatment. First and foremost, that is the right of a patient. So that clearly dictates and guides us all in oncology. We must disclose all information to the patient all treatment options that are available, and then the patient, subject to what they can afford, whether private medical aid, insurance, or if it's a state patient, what treatment options they can take. Now, the oncology sphere in Namibia has developed very progressively in the last decade with private oncology units. We've got the Dr. Abime Cancer Care Center at Central Hospital that has really helped a lot of people. And I want to commend all our Namibian doctors, our nurses, our social workers across the country, both state and private, who work tirelessly to help our people. I think to address specifically your question, it would depend on the diagnosis as well as the prognosis of the disease. Now, like Dr. Pelagia said, there seems to have been some scopes done, so one would assume perhaps it is gastrointestinal, is it colorectal cancer? One does not know. And therefore one does not know if the treatment is readily available in the country. But from a communications perspective, it also unfortunately adds a bit of fuel to the flames that perhaps our healthcare system is not good enough for our head of state. Is this perhaps the reason why he left for the United States, or is it purely because it is his own interest that he wants to go? I think, therefore, if the presidency had consulted and disclosed a bit more concretely as to why exactly our head of state chose to not make use of our facilities here, there might have been a better public uptake on why exactly Dr. Againkop left for the United States. The reality is that our healthcare system is struggling. And the reality is that our oncology, state oncology especially, is struggling. Now, I am the head of the Cancer Association, so I am the voice of the patient. So I have to lobby that we must do better for our patients. And Dr. Peggy and Dr. Bernard and I have had long conversations about what is lacking, what is needed in the last decade, especially since I've been serving, and I have the pleasure to serve with both of them. So I do think that there is a misperception, perhaps due to miscommunication, but that there is lacking in our healthcare system is a reality, and I think the masses feel if it is not good enough for the head of state, why should it be good enough for the masses?
Right.
And that, I think, is the question that we all need to sit around the table and discuss. If it is purely because the treatment, the best possible treatment, is not available in our country, it makes sense because we have got a lot of Namibians that go to South Africa, to Europe, Switzerland, Germany, to the United States, each to their own. I think it is just a matter of clarification. Can this treatment be done here, and why is our treatment facilities, state or private, not good enough for the president?
That's right. Dr. Emvula, I want you to hold on to the question of our oncological capacity, be it from a technological perspective, infrastructure perspective, and also skills relating to that. How incapacitated are we? What is it that we have in terms of machines and technology? What is it that we do not have? Dr. Haufiku, I'm coming back to you with the question, what exactly is cancer stigma? What will be going on when a person is being stigmatized simply because they've got cancer? And is the most powerful man of the land immune to that?
Well, let's for the moment leave out the most powerful men or women of the land, because that has got absolutely no relevance to illness. It's a political classification and social issues. We're just talking about a biological being called human,
right?
Whether you are a man or so. And I want to come to the question of stigma. Maybe I can sum up stigma, and not just against cancer, stigma against anything, basically. I mean, we have, for instance, people with disabilities, that is albinism. Or you just have one eye, then because of an accident and people poke you, in a manner that make you feel inferior. So I would summarize stigma and obviously discrimination as a kind of a psychological illness for the uninformed and ignorant people. And that is often based on irrational fear and the false feeling that you are better than the other person.
Right.
So that maybe I can summarize it that way. It's the key words here are ignorance or uninformed, and the irrational feeling or falsely feeling that you are better than the other person. The truth is that every human is just the same. The difference between us as humans is less than 0.1%. So everybody can be afflicted by any disease. So what is lacking is knowledge. And that is really where we have to start. We can never finish cases of cancer or any disease for that matter by waiting for patient to meet Dr. Emvula there at oncology department or any other doctor for either colonoscopy, gastroscopy, whatever. Maybe prevention in the community, at the community level, in a partnership with organizations such as Cancer Association and others, in a partnership with community leaders. That is what we need to demolish these stigmas and discrimination, because we can pump in as much technical information we want to pump in the public. They just get more bored and bored,
Right.
and even making it worse. We need to make the public understand, and then in the end take care of their own health. Only then can we do better.
That's right. Rolf, hold on to the question of cancer treatment affordability. The president is, he has actually, the president has gone on record to say that the president is going to be forking out money from his own private pockets to fund his treatment and everything else that needs to be done in the United States of America. Of course, saving him the criticism that why would you want to go outside the country and make use of taxpayers' money? So it's on record the president is funding himself out of his own private pockets. But we want to talk about affordability here in Namibia for those that are not President Hage. And while you hold on to that particular question, I want to come back to you there again, Dr. Emvula. How much incapacitated are we in terms of our oncological capacity, in terms of our technology infrastructure? What is it that we have and what is it that we don't have?
Thank you very much. I'm working at the public hospital, but I equally have knowledge of what is going on at the private hospital. At the state hospital, there is, when it comes to radiotherapy, we have got a machine called Cobalt 60. This Cobalt 60 machine has got a source, which is cobalt. It has got a lifetime of 5 years. After 5 years, you have to replace it. And then we have got another machine which is treating patients with cervical cancer inside by the cervix itself.
Right.
The Cobalt 60 machine at the moment has a problem due to the fact that the source has extended its half-life. So we are waiting for a new source probably to come March this year. But this is the 10th year, so it's almost like double the life. So it means that the patients now, it takes long time to treat one patient, sometimes between half an hour to 45 minutes. And also for that reason, we have got short staff. We currently have only really 3 radiographers with a lot of machines that we have. So in this aspect, we are not at the level where we're supposed to be.
Right.
When it comes to chemotherapy, most of the drugs are available at the state. It's the newer drugs, which is called, for example, immunotherapy, that we have some of them, but some of them we don't have. When you go to the private facility they can lay their hands on everything, because the patients are paying, the medical aid is paying. The machine that they are having is also have got a higher energy than ours. So what is happening at the moment, and I'm sorry to say this, I might poke into somebody, we are sending all, let's say about 80% of the patients, we are sending them to the private. So the government is paying for all those patients that are going. So it's really a problem, because for me it means that that money could have helped either to buy a new machine, or at least to buy maybe some of the medications that could have been used for the chemotherapy. So we just hope that we are waiting for that machine to come with a new source by March. If it comes, then maybe things might go differently than they are now.
Right. Yeah. If you're just tuning in right now on Desert Radio, we are on a round-table discussion around President Hage Gengob's cancer diagnosis, a conversation on stigma and impact there. Rolf, I'm coming back to you there with the question of affordability. How dire is the situation, especially when it comes to people who cannot afford to get chemotherapy, and how expensive really is this?
Cancer is unfortunately one of the most expensive diseases to treat. I think when we start with treatment of any disease, we speak about curative treatment, and it's not very often the case with cancer. Certain cancers one can treat and cure, especially if it's in the early stages, but very often because of the late presentation, the prognosis is poor, which means the outcomes are very poor. So this patient will have a long and drawn out intensive treatment, and that is costly, and sometimes even the treatment will be ongoing for sustaining the life of the patient, and then in the end the patient might even become palliative or pass away, which again adds to the stigma. But this is all again this very bad, devilish cycle of, if we break the stigma, if we get diagnosed earlier, we can save more lives. So yes, cancer is extremely expensive. But what we must be very thankful for in Namibia is that the Ministry of Health and Government does pay for treatment. Now, the Dr. May Cancer Care Center was especially established in partnership with the Cancer Association to address this, and the unit is there, and the teams are hardworking, and people come from all across the country, more and more each week, to Windhoek Central Hospital to get treated for free. And this is something that is applaudable and commendable, something that we as Namibia can be very proud of. When I work in other countries with partner organizations in Africa, we find that people are diagnosed with the disease and then told, here is your script, go and get this medicine, or go and get the money for this medicine, or go to a neighboring country to go get radiation treatment. It is not possible. And these patients basically get a diagnosis and a death sentence. We have worked with a partner organization, Max Foundation, in Northwest Africa, where there are certain countries simply where women is told you have breast cancer. These are the chemotherapy and the medicine, and then you must get radiation treatment. They sell their family land, everything that they have. And by the time they get the money, they cannot even get all the medicine and treatment, and the patient in any case dies. The family has nothing, the children have nothing. So it's a really dire situation across low and middle income countries, especially Africa. There's a lot of work that we need to do in Namibia. Decentralization of services, equipment, like Dr. Emvula has said, but at least we have access to, and the state provides care to our patients. So it's the juggling act, balancing act that we need to play at, work at, but we also need to say what we have, we need to build on to make better for future generations. And this is like Dr. Haufiku has said, all stakeholders must come around one table, talk together, take hands to make it better for our patients in our country.
That's right. That's the conversation right here on the station. Dr. Haufiku, I'd like to ask you this question. It's a very political question. As I indicated earlier on in the introduction there, Nelson Mandela openly disclosed that he had prostate cancer in 1998. And at the same time, we have seen presidents that have been diagnosed with cancer. President Jimmy Carter in the US of A was diagnosed and treated for melanoma in 2019. he was no longer the president serving in the U.S. But of course, recently, a few weeks ago, we saw that the defense secretary in the United States of America, that's Lloyd Austin, disclosed that he had prostate cancer. Our own president coming out to make this disclosure. What is it that makes it quite difficult, especially for leaders and presidents, especially on the continent of Africa, not to come out and disclose their health situations? Is it to say that they are afraid that they might be asked you to step down?
Well, Kelvin, thanks for that question. But can I just pebble back a little bit to say something about what Rolf said on the issue of affordability?
That's right. That's right.
Well, I want us to talk about affordability, but much more about capacity, local capacity. And I think Dr. Emvula alluded to that in short. We have to build capacity in a way that as many people who need the services, whether preventive treatment or care, including palliative, have to have access to those facilities. Now, when you look at cancer care, with all the resources that are available at the moment, and much of which Rolf referred to, and that is the state paying for treatment, and much of this treatment are actually catered for only in the private sector, and often at a commercial rate. We cannot talk of capacity when we have only one or two private providers taking care of our cancer patients, all of us 2 million plus. Why I'm saying is that, and I'm glad Dr. Emvula referred to expecting a machine, and I hope this machine is a so-called linear accelerator. Up until now, the state hasn't got a linear accelerator, which is a standard machine for treating most of the cancers. That already says something. And these are the things that we need to put up, not only in Windhoek, but outside Windhoek as well, so that you don't have buses ferrying people from, especially northern part of Namibia, coming to Windhoek and often have to sleep on the floor because of lack of capacity. And as a result, there's just so much disturbance before even the lucky one can get to the machine that is available.
Right.
Now, on the whole cancer care in Africa, there is one seminar research done by Professor Peter Boyle from Northern Ireland, and he launched this at the World Summit in 2017 in Germany. It speaks volume. I would encourage everyone who really take interest in understanding what is the burden of cancer care on the continent of Africa. That will speak volume. Now, on the disclosure issue and the list that you just mentioned there,
right.
I think it's really those that are brave enough or have some political, religious, or social motive to disclose. A lot of people who are suffering and die from cancer don't disclose. They don't. And again, it speaks to how much confidence do we have as public and patients to be able to say, yes, I have this problem, and then I expect to get support. I think we are overwhelmed by fear because of stigma and discrimination. And that is rooted in lack of understanding in the community. And that is a huge problem, like I alluded to this. So big leaders, presidents, ministers, obviously they are caught in a situation where sometimes, look, if you don't even disclose and they find out later, they will say, I'm so secretive, I'm not helping anything. But some just feel so comfortable, and they even believe that by disclosing my state, I am at least motivating one or two people there to also understand that this is a real problem that all of us must address.
Very interesting there. Dr. Emvula, is there anything about what Dr. Haufiku said that you want to address? I'm sure he was also talking about the type of machine that you're getting and hoping that it's the ideal basic machine that is needed right now that we don't have at the same time.
Yes, I just wanted to add something there. Unfortunately, Dr. Haufiku, for our disappointment, we are still getting a cobalt 60 with a multi-leaf collimator. That's what at the moment the ministry can afford. The linear accelerator, as far as I know, has been in the pipeline probably for the last 10 years or more, but it's still in the pipeline. So unfortunately, it's still a cobalt 60, and for meaning that we'll still continue to send patients to the private because the energy on the cobalt is lower than the one that you can get on the linear accelerator.
We are not getting the linear accelerator, Mr. Rolf. Are you concerned about that?
I'm very concerned about it. Like Dr. Emvula has said, we've had this discussion for the last decade. And obviously there are some things technical aspects that one needs to consider, such as the construction of engineered bunker. We need a special engineer to be able to operate the machine. Can we afford this? But then, like Dr. Haufiku has said, what is the burden of this disease on our economy? If we need to keep on treating, if we need to treat more, if we need to keep on subsidizing to pay private partners to do the work for us, everything mounts up. And the reality is that cancer has been around since the beginning. There is not a quick cure for cancer because we are dealing with more than 300 different types of cancers in our very own country. And if we look at the statistics here with the National Registry, it says that the Cancer Association will work with state and private doctors to get all this data as well as the pathology labs. We see different types of cancers. We see more first world cancers also. These are the lung cancers, breast, prostate, brain tumors, which in actual fact it screams to the heavens that we need proper capacity. We need the machines, we need more students at UNAM School of Medicine to learn. I'm very happy that we've got a wonderful group of young medical officers at Windhoek Central Hospital right now that are also going into specialization oncology. A lot have done palliative. We funded a few of them last year. So the future is bright because we have the doctors, but we need the capacity in terms of machines and equipment. We need the capacity in terms of decentralization so that we can look after our patients in the regions. And while we can do as much as we want as Cancer Association, this remains the Ministry of Health and Social Services responsibility as custodians of health to put the right budget in place and to push forth with the plans that we had when Dr. Haufiku was minister. I was part of that team, Dr. Zitzman, Dr. Peggy. We had a brilliant plan of action together for oncology unit here and in the north. Unfortunately, COVID came, politics changed, and the prerogatives of the focal areas changed. But the reality is that we're going to be sitting with an even greater cancer burden within the next decade that's going to overwhelm our public health sector. And if we don't invest today, I can foresee a massive problem within the next 5 to 10 years. So these are topics that we need to address. These are talks that we need to have more often, not just to create awareness about cancer, but when we create awareness and we screen, how do we effectively treat for better outcomes?
That's right. Dr. Haufiku, you just excited this conversation to another level. Linear accelerator, as you say there. I've just Googled the machine. It's a humongous, ultra-modern machine. And how I pray and wish we had this one as well. But of course, what's coming from Dr. Emvula there that we cannot afford. And she's suggesting that instead of subsidizing people and sending them to private institutions, that money could be saved and then we could have this machine. Do you think that this is the sustainable way to get it?
I just say the last part, Kevin. Do I think that?
Do you think that because Dr. Emvula is saying that instead of sending patients to private practices and having to subsidize their cancer treatment, we could make use of that money, save it, and buy this linear accelerator? Do you think that's a sustainable way of raising the money and getting this machine for ourselves?
We need to get a linear accelerator for the state.
Right.
Yeah, well, that's due as of yesterday or yesterday, or maybe 10 years or 20 back.
Right.
Dr. Emvula and I were in Boston in 2000. And Dr. Emvula, 2017 or 18?
2018.
Yeah. She knows exactly what I'm talking about. And I fully understand what Ralph is also saying, which is basically what we are all saying. But the reality is that we need a linear accelerator from a technical aspect. For instance, Dr. Emvula will tell you that if a young person or even older with skin cancer, let's say in an albino patient, the machine that we have currently provides difficulty at the stage because it's an old cobalt-based machine.
Right.
It delivers fixed dose of gray or the stuff that Dr. Emvula then used. Linear accelerator, at least you can manipulate and maneuver to give the required dose for the skin and not destroy the patient's skin. I'm just giving an example to motivate it. We
Right.
need a linear accelerator and preferably a state-owned linear accelerator, maybe one or two,
Yes.
so to say.
Yes.
You know, the other thing, machine, we don't have. But let me not give you the impression that there are no linear accelerator here. I mean, I just don't want to promote private provider, but there is at least one linear accelerator that I know in the private sector. Dr. Emvula knows, Rolf knows.
That's right.
We're not talking about private company on radio here.
That's
But
right.
we know
Yeah. It's about the masses. How do we give access to everyone? Yes.
Yeah, this is the problem. My friend, 60% of Namibians live in the northern belt of Namibia, from Katima to Hunene. 60%. 60% or so of patients Dr. Emvula treats every day possibly come from that northern belt. We need one right there in the north. Linear accelerator. That's my take.
Right, Doctor, in 2018, when you went to Boston with Dr. Emvula, you were still our minister there. I'm just doing a quick Google search here. And, of course, you did work with Dr. Emvula, and we are very, very happy to have you on this program. And, of course, building on this program, 5 minutes to go to 2 o'clock. We're just rounding off our conversation there. Dr. Emvula, do you think that the diagnosis of President Hage Geingob could be used as a platform to enhance advocacy for early cancer screening?
Well, that's very difficult to say. The thing is that we don't really know what type of cancer he has.
Right.
And accordingly, if we know exactly what was it, maybe we could, let's say if it was prostate or it was colon, because those, for example, are the type of cancers that you have in the family line. They are genetic. Then you can add maybe breast also. They are almost in the same line. You could use that as a platform to sort of motivate the population to say, you see, even the president has come out, so we know that cancer is not immune. Everybody can get it. Please come out and get tested. But then we'll face another problem. People get tested, and where are they being treated?
Right.
So that's also a problem.
There you go. Right. Rolf, you want to say something about that?
I think every opportunity that we have to make noise for the right reason is positive. One is cognizant that a cancer diagnosis is a terrible thing for any person because people automatically feel that it's a death sentence. The reality is that if we continue to have these conversations, if we have people in prominent positions or public positions that speak more up about it, we will be able to break the stigmas. But we must also use this as a vehicle, like I said, to launch an investigation to say, why can these prominent people not be treated in our own country? Why are we not doing better? And then we need to formalize this plan and get our act together as a country and make it better for even the most vulnerable of the vulnerable, whether it is the jobless, the homeless, the street, the cleaner, the teacher, the banker, the doctor, up until the lawyer, up until the politician. Everyone must have access to the best possible health care in our country. That is what we must aim for.
That's right. This has been an eye-opening cross-pollination of opinions really coming from the experts that we have right here in Namibia. Dr. Haufiku, our former health minister, and of course a man that continues to contribute to public discourse on matters of health and other matters there. Doctor, for the time that you gave us there, we do appreciate you, Doctor, and we would like to come back to you next time when we are having such conversations so that you can help build our understanding, especially when it comes to health matters. Do we have an awesome day, sir? Dr. Haufiku?
You want me to say last word?
Yes, if you can say your last words, but we are saying to have an awesome day. After that, you can still say your last words, sir.
You were asking me?
Yeah, I was saying that no, we thank you for
Okay. Thank you very much.
That's
Thank you.
right.
You're
Have an
most
awesome
welcome.
day.
Anytime.
That's
Thank
right,
you.
Doctor. Rolf, thank you
All
so
right.
much and for the work that you're doing at the Cancer Association of Namibia there. We appreciate you.
Thank you. Till next time.
That's all right. All right, Dr. Emvula, our guest in the house, we do appreciate you really for taking the time to come over here. It's not every time that you have an oncologist coming to the studio to talk about matters of cancer, but we appreciate you, ma'am, for coming through.
Thank you so much. It was a pleasure.
That's all right. Building our conversation and understanding of this very delicate topic in the streets of social media. That's the conversation right here on Desert Radio. The Conversation. That's what we do every Thursday. My name is Kelvin Chiringa. All the way from 1:15, 2 o'clock is the time that we dock. And I say, do have an awesome remainder of the day.